All right, well, let's get started. So the plan for today is we're going to finish off Chapter 9. So we need to talk through all these joint actions, so all the joint movements so that we have some vocabulary that we can apply to the chapter on muscles that we'll be starting into next. There's a little bit of a ditty on joint disorders also. I've also just finished, I did not actually get it posted, I was about to and then I didn't, but I finished an answer key for the Chapter 9 homework, so I'm going to post that. I think that'll largely be how we'll cover that homework assignment in terms of review of the homework assignment. But we may have time to either pull out that answer key, talk out the first couple of questions, or start in the Chapter 10 discussion later at the end of class today. For Friday, we're going to continue on into the muscular system chapter, and we will, that chapter is partially covered, I think it largely is covered in the homework is how we're going to be doing it, but there's sort of some broad concepts about muscle system that we'll talk about, and then we'll also sort of I'll do sort of like a brief overview of all the muscles, or at least many of the muscles, to give you sort of a framework, but then you're going to need to spend time just with your book, with the models in lab, learning through the muscles for that chapter. And so we'll talk more about that in a little bit. Final announcement is just as a reminder, I'm planning to do a quiz on Canvas on chapters 8 and 9 over this weekend. So that'll be due Sunday night. I'll get it posted tonight or tomorrow, depending on how things go. Any questions you guys have? Yeah? Do
you mean next Friday for the homework?
Which homework am I talking about? Yeah. The homework is not due Friday. It's just we're going to start into the chapter on then. But then the homework itself, I think, is due probably next Friday. Yeah, sorry about that. Other questions? Okay. I also just wanted to acknowledge, so welcome to Dr. Karen Powell. So she's Vice President of Academic Affairs, so good person to know for all. That guy. All right. Other things we can do with shoulders as well as other joints include elevation and depression. So your shoulders, this is not so much something you're doing with your humerus. This is something you're doing more with your scapula, but this is kind of like shrugging your shoulders. So we can elevate and we can depress our shoulders. We're going up or we're going down. So elevations can be defined as a movement that raises some bone vertically. And so it's really about, it's not like, a flexion action where we're going up like this. That's not really a vertical ascension. I mean, it is kind of going up, but we're talking about just sort of only moving upward in the vertical plane. Can you think of anything else you can do this with? So you can, vertically elevate your shoulders. Is there anything else we can vertically elevate you can think of? What do you have? What are you doing? I can't tell you what you're doing.
My neck.
Yeah, okay. Maybe a little bit with your neck. I'm not sure if that might be a little bit more of like an extension flexion thing that we're doing if you look, in an X-ray. Anybody else think of one?
Like heels?
Yeah, although we have different words for heels, so I'm going to come back to that one. One that I usually think about that usually comes up is your mouth, though, right? So like every time, this kind of action. So this is you're elevating and depressing your mandible as we're masticating or talking up here. You're moving your mandible up and down. That's another common example. Let's see, others. So protraction, retraction. This again is with shoulders. Shoulders can do all kinds of things. We've talked about it. It's a super flexible joint. Protraction is, again, this is something you're not so much doing with your humerus. So this guy's already flexed at this point, his shoulder. But then he can move it forward or he can move it backward. And so moving your shoulder forward, that would be protraction. Moving your shoulder backward would be retraction. And that's mostly something you're going to be doing with your scapula as it's sort of moving, scapula and clavicle, as it's moving sort of around the rest of your body. So protraction is defined as anterior movement in a horizontal plane, straight forward. And then retraction would be posterior movement along the horizontal plane. There's no swinging that's happening here. It's just like only along that plane. Rotation. So rotation is where we're picking one particular joint and we are sort of rotating around that. And so this is another thing that your shoulder can do really well. So that she's got her arm, her elbow bent here just so you can sort of see it more dramatically. But what's turning as she's doing this, that pivot is happening at her shoulder, right? So that's your humerus rotating in your glenoid cavity. So this is not the same as abduction or adduction, and it's not the same as flexion, extension. This is a third axis of movement that you can do, this rotation action that's happening here. And so it's demonstrating she can do this with her arms. She can do this with her legs as well. In the case of arms and legs, because they're mounted on one side of your body, you can define the rotation in terms of medial versus lateral rotation. So a medial rotation is where you're rotating toward, in a medial direction, towards your midline, whereas lateral rotation would be rotating away from your midline. Threw that up there. What else comes to mind you can rotate? Yeah, head's a nice obvious one, right? So that's this no action. So that's your, we talked about in the chapter 7, that's your atlas rotating on the dens of your first 2 cervical vertebrae. That's a good classic rotation example. Yeah, go ahead.
What would you just say that's just rotation?
Yeah. Yeah, so like that, this is more, we just define it as like a left rotation, right rotation, because you can't go medial or lateral because you're on the midline already. So this would be sort of left and right rotation. And of course, we can do that too with our spine, your vertebra. Another one that sometimes people mention as rotation, but we really have more specialized terminology for it, is what happens in your forearm. So this, it's kind of a rotational action. It is on a pivot joint, and we talked about this the other day. So this is your radius and your ulna kind of pivoting past each other. But we use more specific terminology for this out in our forearm. So we call this supination and pronation. So supination, I'm sorry the lights are down, but I got tired of turning the lights on and off. Supination is your anatomical position. So in anatomical position, your palms are facing forward. And so that's what's depicted here. And actually, I like this picture because it shows you why we define that as anatomical position. So in supination, when your palms are facing forward, your radius and your ulna are lined up parallel to each other, right? So your ulna is on the medial side, your radius is on the outside, or on the lateral side. They're right nice and parallel to each other. If you do this, we call that pronation. So you're pivoting them. And when you do that, your radius crosses over the top of your ulna, so they're kind of crisscrossed. So this is just because this looks cleaner, I guess. We're defining that as anatomical position, where they're nice and parallel to each other, whereas when they twist like this, that's considered a pronation motion to get to that point. Your book does this thing where it says pronation is like, in order to dribble a basketball player, like a pro basketball player, you have to pronate. And that way your fingertips can be sort of facing down. So that's a nice way to remember it.
Isn't pronation also like when you walk on like the arches of
Yeah, so pronation and feet, I actually just added text to that. That's coming up in a little bit. But that's, yeah, it's kind of a weird combination of several different actions to pronate your foot. But it does result in you having your toes kind of pointing outward as you're walking. So a lot of people this is a big thing with runners where if people do pronate a lot, they have to wear stability shoes because otherwise you have all kinds of ankle problems and foot problems. Yeah.
So pronation would also deal with pitchers throwing a baseball.
Yeah. So if you are, or like a curveball, right? So if you're throwing a curveball, you can't see me, but if you're throwing a curveball, you do kind of like snap your wrist like this, and I guess sliders you do this too. I never threw a slider or knew that I was doing it. But yeah, in both those cases, you're kind of snapping your wrist in a pronation fashion. I think you can do a screwball, which would be the opposite, where you're supinating. That ruins people's arms, is my understanding. But that would be a supination action. Let's see. OK, so that's pronation, supination. We will return briefly to that when we get to feet. But mostly we're worried about that in the arm. In terms of your trunk, we've already used some of these terms. So you can flex and you can extend. So that would be flexion would be bending. So that's decreasing the angle of your trunk. So I'm sort of pivoting, or she's pivoting mostly around her hips here. But if she was pivoting, or not pivoting, but if she was flexing, extending, she could do this with her vertebral column too, right? And that's just decreasing the angle of her body. Extension would be going back up to anatomical position. Hyperextension would be leaning back this way. Trunk can also do a lateral flexion too, though. So lateral flexion is where you're kind of bending off to the side. I almost want to call that like abduction, but that's not what it's called. It's a lateral flexion in this case because she's sort of flexing, but it's off into the lateral side of her body as opposed to flexing forward. And you can do that with your head as well, anywhere within your vertebral column. Your hands, you're capable of doing all kinds of neat things with your hands. And that's, as we've sort of talked about, I think one of the defining things about people is we have such incredibly good manual dexterity compared to most other organisms in terms of what we can do with our hands. So certainly we can, it's not even up here, but we can flex and extend our fingers, right? So this is flexion, this is extension. You can, over here it's showing you that you can abduct your fingers, but you can also adduct your fingers. We talked about that briefly already. Your wrist can also flex and extend, but it can also do something that's kind of like lateral flexion too, right? And these actions, we define it basically based on which bone you're going towards. So if you are going towards your ulna, so you can always find your ulna, which is your elbow, and kind of trace it up your arm. So if you're flexing toward your ulna, I think this person's using the other hand from me. Yeah, that's why it looks different. Let's get the same hand. So if you find your ulna and you then flex towards your ulna, that's called ulnar flexion. Whereas if you flex towards your radius, that's called radial flexion. And then the thumb is the really cool one because it can do these sort of additional actions. So we can do this opposition action that most other animals cannot do, where we're bringing our finger all the way across in front of our hand, and it comes in contact with the other side of our fingertip if we want it, or of course this is what we do when we grip something. So that opposition movement, that's called opposition. That's sort of an additional extra amount of flexibility that's provided by that saddle joint that's sort of right there at the base of your metacarpal of your thumb and that carpal bone. And then feet. Lots of things we can do with our feet as well. So in anatomical position, when we're standing, our ankle joint can kind of go up and down from there. Those are both considered sort of like a flexion, but they have different terms. So if you are pointing your toes down, so you're standing up on your tippy toes, that's considered plantar flexion. This is really more of like an ankle action, right? So plantar flexion is sort of pushing down up on your tippy toes. Whereas dorsiflexion is doing the opposite, where you're arching, you're sort of pulling your foot backward. There's this tibialis anterior muscle up here that you're sort of pulling upward. And most of the time over the course of a walking step, we'll kind of do both of these things. So like as you're sort of reaching forward, we kind of dorsiflex. We land, although I'm a sort of a heel striker, so I probably land more on my heel than I should, but I'm pretty much fully dorsiflexed oftentimes when I land. Then you kind of set down, return to anatomical position, and then you push off with a plantar flexion. So you'll usually go through all three of these sorts of states. The zero position is your anatomical position, but you'll kind of go through these three over the course of a step, whether it's walking or running. We can also do inversion and eversion. Inversion is just basically twisting your feet so the soles of your feet are pointed towards each other, whereas eversion is the opposite of that. They're pushing outward. I did add this in. I'd been meaning to, and I'd forgotten to put this on your slides. But supination and pronation, I don't want to dwell on this too much because it gets kind of complicated. But the idea with supination pronation is that you are kind of combining plantar flexion, inversion, and adduction. And so the result of this is that when somebody lands on their foot, I don't know how to illustrate this, you're kind of you are landing such that your toes end up sort of facing each other. So if you sort of imagine my hands or my feet, you're kind of landing like this, and they sort of face each other. Whereas pronation is the opposite. I see a lot of people that do this. I think especially as people start to get overweight, they are prone to doing a pronation sort of an event where their toes will sort of go out afterwards. So they're sort of walking kind of like this as they move along. The reason that they're called pronation and supination, I had to kind of prove this to myself. I'm going to turn the lights up. But if you start, so imagine your foot is your hand, or vice versa. And then if you pivot your palms such that they're starting to face toward each other, what tends to naturally happen to my hands anyway is that my fingers start to point outward as I start to pivot like this. And so I'm actually starting into kind of a pronation kind of an event, whereas supination is sort of the opposite thing kind of happens to me. I'm sorry, I did that backwards. So as I start to face forward, yeah, there we go. As I start to pivot my palms such that they face each other, so this is a bit of an inversion, I start to actually point my fingertips towards each other. So this is actually moving towards supination, which is anatomical position. Whereas if I try to point my palms outward like that, my fingertips kind of go outward, and this is kind of a more severe pronation that I'm doing. I think that's where the terminology comes from, but this is how they're used when you're talking feet. I really want you to not stress too much about this. I focus on supination, pronation as far as wrist movements, but if you get into athletics training and that kind of thing, you have to be aware of pronation, supination. So this is where the terminology is coming from, because pronators in particular, they tend to have additional compensation with their shoes and stuff when they're running in order to make sure that they don't hurt themselves because of the action of their foot. Is that okay? Make sense? Okay, so given all that, we just went through a bunch of vocabulary. I want to revisit this lady and try to figure out what it is that she is doing. So if you can kind of work your way through each of these joints, what's happening with her phalanges and her wrists, her forearms, elbows, shoulders, neck, all the way down. See if you can sort of define what she's doing at each of these cases, and talk to the people around you. We'll take like 2 or 3 minutes, but just sort of like try to define this to yourself. I think this is a neat way to sort of study these things and make sure you're comfortable with actions. Okay? And then we'll run through it. So take 2 or 3 minutes, see if you can figure that out, and then we'll talk it out. All right, so last little bit in this chapter is to just give you like a Cliff Notes version on a couple joint disorders that are common or at least interesting. So we'll talk about, I think I got 2 or 3 slides on this stuff. So joint injuries are relatively common, and they basically fall into, assuming there's no damage to the bones themselves, they fall into maybe 3 major categories. One might be a cartilage tear. And so cartilage tears, typically you're dealing with some of the sort of stabilizing cartilages associated with certain key joints. So a torn meniscus in your knee. We've got a pair of menisci in our knees that are basically shock absorber pads. They're made of fiber cartilage, and they can tear. It's a little hard to see in this picture, but the tear in this case, so this is a meniscus. This is through a scope that they're looking. And this is torn sort of right in this little notch right here. So this should be connected like this, and it's not. And so as a result, this person would need to have some kind of a surgery. Most of the time, this can be solved through an arthroscopic surgery. They just kind of go in and remove the torn part, or maybe clip off the bit that is torn. So it's relatively non-invasive, but you still have to have like three structures. You have to have a camera and then a couple probes that go in there in order to accomplish that surgery. The trouble with cartilage tears is that they don't really heal. And so if you have a torn meniscus, surgery oftentimes is the only real option for you because they are, as we've sort of talked about, cartilage is not vascularized well at all. And so there's relatively low metabolic rates. There's low capacity to heal the structure once it has been damaged. Other common examples of cartilage tears that you see in a lot of sports injuries include like torn labrum. So we have a fibrocartilage labrum around our glenoid cavity as well as around our acetabulum. Those things can also tear. And again, it's fibrocartilage, doesn't heal very well. A lot of times there's some kind of surgical surgery that's required in order to resolve the pain from the sort of interference of the torn structure on your shoulder or on your hip. When somebody has a sprain technically, when the word sprain is properly used, it's specifically referring to damage to ligaments. So there you have stretched and usually torn ligaments. Doesn't have to be completely torn, but there's some actual damage to the ligaments that has occurred, or to tendons that are serving a similar function in terms of stabilizing a joint. These again are not well vascularized, so they are sort of annoyingly difficult to heal sometimes, and it may take just as long for a sprained ankle to heal if it's a really severe sprain, where there has been substantial tearing or damage to the ligaments or tendons. That can take just as long as it takes to heal a broken ankle in some cases, because they're sort of notoriously slow to heal. And the trouble with them is that while bone ultimately, usually if you get aligned well, will basically heal all the way and sort of you'll get full function restored. A lot of times once you've torn, damaged a ligament, it is prone to redamage because it doesn't really heal all the way oftentimes. Dislocations, what you're dealing with there is where bones are forced out of alignment, so the joint capsule that surrounds the ligament surrounds the joint has been damaged. Those are composed of ligaments, so really like dislocations are really sort of an example of a sprain where you've damaged those ligaments that are supposed to keep the joints all connected and aligned properly. And in order to dislocate, usually you have to damage some of those ligaments. So again, they're kind of slow to heal, and once you've damaged them once, they tend to have extra give in them. The ligaments do, and the capsule does, and so as a result, it invites subsequent dislocations. So once somebody dislocates their shoulder, they're prone to dislocating it time and time again throughout the rest of their lives. There's also a variety of inflammatory or degenerative conditions that are associated with joints. So we talked briefly about bursitis tendinitis. This is where either bursa or tendon sheaths become inflamed, and that leads to a substantial amount of pain and can be debilitating amounts of pain as a result of this, this kind of inflammation that can occur. You can also have inflammation in the joints themselves. So probably the most common is osteoarthritis. This is like standard classic arthritis, so the type of arthritis that most people get some of as they get older. What's happening here is that the articular cartilages start to degenerate within your joints. So these are those hyaline cartilage capsules that are sort of, or caps is what I meant to say, that are kind of over the top of each individual bone that is part of that joint. And so then as the bones move past each other, instead of having that nice hyaline cartilage to rub on one another, now we start to get bone tissue actually starting to rub on other bone tissue. And so you get wear, tear, you get imbalance, you get a lot of inflammation as a result of that abrasion that starts to occur as bone starts to sort of emerge from beneath that articular cartilage cap as that articular cartilage degenerates. So just straight up wear and tear can lead to this. This is something that happens more often as one gets older, but it can happen at younger ages as well if you have substantial damage to your cartilages. And if there's any kind of imbalance in your cartilage processing, that can also accelerate the rate at which osteoarthritis can occur. Osteoarthritis is different from a couple other kinds of arthritis that you'll hear about. So like rheumatoid arthritis is a different kind of arthritis. You still have inflammation. The difference is that in rheumatoid arthritis, this is actually an autoimmune disorder. So here you have your own immune system is starting to attack usually it's attacking your synovial membranes, or it's attacking your articular cartilages, and the result is that you have sort of assault and damage, oftentimes a lot of scar tissue that forms in there, and it can be really severe. So this picture, again, the projector is a little dim, but you can kind of see this poor person has these really sort of deformed joints between their proximal phalanx and their metacarpals. And these are actually, what's happened here is that because they've had so much inflammation in these joints and they've started to get scar tissue forming, the bones have actually fused together. And so they're unable to move these joints anymore, and they've sort of contorted at sort of an awkward angle is where they've ended up as a result of the rheumatoid arthritis. So again, the key thing here is that you've got an autoimmune disorder where your own immune system is attacking structures, usually synovial membranes, within your joints themselves. Oops. Another kind of arthritis that I guess I didn't put on here is you'll hear about gouty arthritis. In gouty arthritis, I'll just sort of mention this because you might have heard of it. You have uric acid crystals that are forming inside your joints such that you have basically like little tiny crystals in the articular cartilages such that when you move the cartilages past each other, they start to have a lot of abrasion. It's almost like having a little sawdust or something that's in there. And it results in a substantial amount of inflammation as well. Any questions on arthritis, sprains? Yeah?
For bursitis and tendinitis, how would you treat
Yeah, like the most common treatment is just to stop what you're doing. So like I have kind of a chronic tendonitis in my knee, and I talked to Dr. Boland over in physical therapy, and he basically told me I should stop running for a little while, and I sort of refused. But that's oftentimes that's the treatment, is sort of reduce the amount of physical trauma that you're subjecting them to, let them kind of settle down, and then you can sort of ramp back up again. Sometimes in severe cases or cases where you're trying to sort of accelerate the healing process, people do like a cortisone injection. So if you inject cortisone, cortisone is an anti-inflammatory, and that might be able to dampen down the inflammation. Even just things like putting pressure and stretching, that can often help to sort of increase flow of blood into the area, which can help to sort of resolve the inflammation. A lot of times, though, it is just stop doing what you're doing and give yourself time to heal, and then you'll be fine. Did I see a hand over there? I see a hand there. Yeah. I do feel like I don't know. I'd have to double check. I think it does become more common as one gets older. Decent number of autoimmune diseases are like that, where you encounter some kind of an environmental trigger or something that causes you to develop antibodies or reactive cells that will attack some particular tissue within your body. And so oftentimes is happening more often as one gets older. But I guess that's not universal. Like type 1 diabetes usually hits people really early on. That's an autoimmune disorder. But yeah, I would guess if I go looking, and I'll try to go look, that it would show increased incidences as one gets older. Crohn's disease does that too. It's usually more like 20s, 30s, but again, it's hitting people not as 10-year-olds oftentimes. Other questions? These are good. All right. Last slide was just that guy that's on the homework. I'm just going to try to post an answer key, but I'd like you to look at the answer key, and then at the start of next class, if you want to talk about any of these things, because we just kind of did this with the lady. He's doing something slightly different. He's got some abduction going on. But again, take a look at that and see if you can see if you have any questions or disagreements with what I posted in the answer key. So we have about 8 minutes left. So what I would like to do is start into the next chapter. And that's the skeletal system, or the muscular system. And I put the skeletal muscular system because really we're focusing not on all the different muscles that are in our body, but we're just focusing on the skeletal muscles. So those muscles that are responsible for moving bones around. We're not looking at smooth muscle, and we're not looking at cardiac muscle in this unit. We'll tend to focus on those in other units when we're working through. But I always paired this chapter tightly to the joints chapter, because a good portion of what this chapter is about is trying to learn all the various muscles that exist within our body and what specific actions do they achieve for us. And so you'll need the vocabulary we just did at the start of class in order to be able to describe with sort of detailed nuance vocabulary what specifically each muscle is capable of doing. So this is the outline of how I've set up the chapter. So and this more or less follows what your book does. There are some sort of general concepts about muscles, and there's not a ton of information there, but it does give you sort of details about sort of general processes about how the muscular system is oriented. So we'll sort of run through all that, and we might get through some of that today. Then the other thing, the bulk of the chapter is just going through all these different muscles. And so you're going to be required to learn for our class something on the order of about 120 or so muscles. That's of about 600 in the body, but they're all the major ones that do most of the major actions. And that'll give you a sort of a nice level of detail that you can carry with you as you move into classes in the future. So as I was kind of saying, a big part of this chapter does come up on the homework. So let me describe how the homework works, because it's a little bit different from how I've done other homework assignments. So the first one, part 1, is the part that you are actually going to be turning in. And so what I've done is it kind of mirrors what we just did with the joints chapter. I'm focusing on our 4 major joints that we're focusing on. So that's shoulder, elbow, hip, and knee. And so what I've done then is for each muscle that's directly involved in movements associated with those 4 joints, I've put them on a series of tables for you on this homework assignment. And your job is to fill in on the table the actions for each joint, for each of these muscles. So like what action do they allow you to do? And that's going to be using that vocabulary we just did. As well as you have to indicate what are the muscle attachments, so the origins and insertions. So the origin is the muscle attachment to the bone that usually doesn't move when the muscle contracts. And then the insertion is the muscle attachment onto the bone that does move. And so you'll need to fill in that information. So this is where all that stuff you're learning in lab, all the little bumps and processes and stuff that are on bones, many of those are muscle attachment sites. And so that's where all that information comes back. There's about 45 of those muscles associated with those 4 joints. And so those are the ones that we're going to be learning in the most detail in terms of both actions as well as origins and insertions. I do like your book Saladin, but I do not like how your book Saladin does this particular bit in your chapter. And the reason for this is that I just find Kenneth to be rather verbose, to the point that like he's writing paragraphs describing actions of muscles, which none of that is untrue, but it's kind of hard to learn from, and it's more detail than I think we need to know. So what I did is I actually scanned a different chapter. It's on Canvas. You can then use that chapter, and there's even blue words in that chapter that you can use that are a bit more concise in terms of knowledge and information that you can use to fill out this table. So that's the language I would prefer to use because it's much more concise and I think much more approachable. So that's due, I think that's due next Wednesday. There's a part 2 of the homework assignment, though, and the part 2 is a list of muscles. And it includes all the 45 muscles from part 1, but it also includes about 80 more. And in this case, you do not need to learn the origins and insertions for all those extra muscles, but you do need to know all the actions for all of them. So this gives you, again, like I said, about 125 total muscles that you're doing. It gives you a nice level of detail. There's still another 400 some muscles that you could learn about if you ultimately want to, but this will give you, for all the major prime movers as well as a lot of the synergists that are really important for most musculoskeletal actions. Most of these also appear in your cat, or they appear on the human models. So the idea is that there should be good synergy between what you're doing here and what you're doing in lab. In terms of how to go about this, I really do think there's a lot of muscles that you're working through. So you're complete the table, and I think that'll make a nice study resource for yourself. But I think you just want to kind of schedule this out. So this is all going to appear on the Joints and Muscles mini exam, which is on the 25th of October. So that's 23 days from now. So you can kind of scale this out. So if you parse out, if you do so many muscles per day, you should be able to work through the entire list over a period of time in more of a sort of a manageable format. Whereas if you wait until the 20th to start learning these, you could be in trouble, right? Because it's just a whole lot to learn in a short period of time. The text, I think, does a really good job of explaining all these. The models in lab, I think, are really good. There are those skeletons. There's one skeleton in lab that has blue and red marks all over it. And the blue and red marks are muscle attachment sites. So it can actually, I think, be really handy as you're learning origin insertions for these 45 muscles. Go find that skeleton in lab and just spend time with it. Find all those muscle attachment sites. It might help you visualize. Especially in terms of actions, one thing I think that's really helpful is if you just try to palpate yourself as you try to move each of these muscles individually. So if you're working on your triceps, you can just sort of find your triceps muscle and then do the actions that are described in your book. You're like, oh yeah, look, that's doing that. And you may be able to, that allows you to sort of personalize all this information to your own body, and so you can use your body as a reference. And you get to use your body as a cheat sheet when you come into the quiz as well, because I'm certainly not taking that away from you. Let's see, I mentioned the skeleton. I also posted, I call it a coloring book. It's basically black and white images, but it goes through each muscle individually, and you can kind of color those in. If you do that while thinking, it might, sometimes people find that helpful. If you're just kind of coloring, then maybe it won't help. But if you're using that as a way to help you focus on each individual muscle in turn, I think that can be a good thing. And then the other thing I'll just say is that a lot of the names provide really descriptive information. So we have this whole collection of muscles that are called adductor something in our thigh. And you could guess, what action do you think an adductor does? It probably adducts your thigh, right? So there is really specific information that the muscles are often named in terms of their action or their specific location, and you can usually figure out from that information what the muscle will be. So actually, I guess I'm out of time, so we won't be able to start the system itself. But what we will do is, we will do that on Friday, but you can start this homework anytime, and I do recommend getting started on it and plotting this out for yourself, at least starting this weekend so that you don't save it to the last minute. Okay? All right, that's it for today. I will see you.